Briefly through the most relevant aspects when it comes to cardiac CT. And importantly, at the end of each video, we will go together through real cases. So you will also see practically and hands-on what I'm doing when I'm analyzing real coronary CTA cases. And this will help you also to reproduce these techniques and apply this to your own patients at home. First, some consideration about patient selection and preparation. It's important to acknowledge the fact that coronary CTA or CCTA is most suitable for patients with a low to intermediate risk profile in suspected coronary artery disease. That means the main strength of this technology lies in those patients. If you have patients with high likelihood and severe calcium burden, for instance on your calcium score acquisition, then it may be more appropriate in those patients to go directly to the cath lab and perform invasive catheter angiography. And CCTA has the main advantage over catheterization that you can visualize the surface of the vessel and also really analyze the wall and cross-sectional images, and this is not possible with catheterization. And in addition, it moves towards also cardiac MRI techniques with functional assessments possible and further atherosclerosis characterization. Most important for getting started is to know how appropriately position and prepare the patient. So the scan will be performed with the arms elevated above the head. That means first the appropriate positioning of ECG electrodes is very relevant. The ECG electrodes are 4 and 2 are between the nipple and clavicle on the left and on the right side, and 2 below the nipple at the same distance from the nipple, and the left one close to the apex of the heart should be a bit more below than the right one. When the patient elevates the arms, just test it in advance if the electrodes have really a firm contact to the patient's skin. You may also shave the patient's skin when there's a lot of hair, or you can also use some contact gel, because very often you have ECG problems that are only because of contact problems with the ECG electrode, so you want to avoid that in advance. The torso of the patient is in the middle of the scan field and gantry. This is indicated easily by the laser lines from the scanner and can also be performed semi-automated using the fast 3D camera, which makes this part potentially more faster and more consistently for each patient. Also important is that it's very commonly forgotten is to practice the moderate inspiration breathing command with the patient in advance. So I always tell the patients that it's not like when they would like completely breathe in, it's just like a relaxed, moderate inspiration, and tell the patient yourself to stop breathing, hold the breath, and breathe normally. And once you practice that, the patient will also be able to reproduce this in a very consistent and a relaxed way during the scan acquisition. It's important in cardiac CT scanning to establish a relaxed and calm environment for the patient. So in the best case scenario, you would establish a separate preparation room where we can talk with the patient, put the cannula in, and just establish a relaxed environment, because cardiac CT is performed with lower heart rates, and when the patient is relaxed, of course the heart rate will also be lower inherently. Then this brings us to the second part of heart rate control. Lower heart rates are always desired, not necessarily mandatory anymore. However, a lower heart rate allows you to use really low dose acquisition because your scanning time gets shorter and the pulsing window also gets shorter. That means the amount of or the length of maximum dose is shorter when you have lower heart rates. And lower heart rates you establish with beta blockers intravenously, preferably metoprolol. Please inject this slowly and titratedly. You can give 5 up to 50 milligram intravenously. And it's really important to not inject this all at once, because you will cause likely AV block, which should be avoided at any rate. So we tend to only give 3 milligram, then wait at least 1 minute, see how the patient reacts and how the heart rate reacts, and then we give this separately. And also we control blood pressure if we think that the heart rate would decrease too much or too quickly. Nitrates are also very important to facilitate a coronary dilatation. It's supposed to avoid coronary spasms that can rarely occur during acquisition, so you want to avoid that and apply this mainly sublingually, but there are also patches available for the patient's skin. So the contraindications for beta blocker and nitrates are relatively similar. If the patient has low blood pressure, an AV block, asthma or severe aortic stenosis, you should not give those medications. For nitrates, there is an exception in men. You also have to ask the patient if the individual took some vasodilatative medication like Viagra in the past 2 days, which also would then lead that we don't give nitrates. Contrast injection is another very important part, that you consider this protocol in advance and plan it accordingly. When you have most recent scanner technologies like second and third generation dual source CT systems, you will be able to have automated tube voltage selection or KKV, and this software decides based on the topogram what KV is selected for the image acquisition. The topogram will look like this. It's similar to a chest X-ray, and it's much more accurate than just the body mass index based KV selection, because you will have some individuals that have a lean chest and a very tall abdomen, and vice versa. Some athletic patients have a very big chest, despite that the BMI is quite low. So this topogram-based KV selection has been shown to be much more accurate. The good thing about lower KV levels is that we have a much greater iodine attenuation. Speaking in very simple terms, the image gets brighter the lower the KV level is. And this in turn allows you also to lower the contrast media dose. And in parallel, the radiation dose is much decreased with lower KV levels. Regarding the amount of contrast media, you should also consider the body mass index, because in very obese patients, you may give 10 milliliter more contrast, and vice versa. Very lean patient, you should reduce the amount. In best case scenario, you choose a triphasic injection protocol consisting of a main bolus that is in the end supposed to opacify the left ventricle and the aorta, and of course in between the coronary arteries. And as a second, you have the diluted bolus that is contrast media, like about 30% contrast media, and the rest is saline. So you also have a slight right heart opacification that allows you also for right heart assessment, and this is followed by a saline chaser to clear the superior vena cava. So in the end, you see on this image here is this the clearing saline chaser. At the dual cylinder injector protocol, this looks then like this. So for instance, here in a routine 80 kV scan, we choose 40 milliliter of contrast media at 100% concentration. The flow rate was 5 cc per second or 5 milliliter per second. And then you can also see the injection time of the first, the second, and the third bolus. This sums up to 24 seconds and is almost the average of the preset delay on the scanner, which would be about 23 seconds. This would be an optimal case in an 80 kV scan. If we have higher KV levels, we would add to the first bolus some contrast media. What still is lacking is that a clear standardization of this KV adaptation. This is under current investigation. But for an alternative, meaning a biphasic KV adapted contrast media injection, there is already wide evidence about standardization. So we have shown, for instance, that with a biphasic injection, you can nicely adapt the contrast media to the KV, starting at 40 milliliter. with a flow of 4 per second, and then you incrementally give 10 milliliter more with each 10 more kV, and upon 100 kV you will switch to a 5 milliliter per second flow, because you also have to inject the contrast media faster. This is investigated with a concentration of 370 milligram iodine per milliliter, and each of these settings is followed by a 50 milliliter saline flush. And you see nicely here on the right that with this protocol you have a comparable attenuation both subjectively and quantitatively for the right coronary artery for 2 patients at 70 kV and 120 kV. So the actual cardiac CT image acquisition. As a first step, you have the topogram. So these bars will indicate here on the slide the upper and lower range of scanning. Based on the topogram, you also get an impression about the cardiac anatomy. And you see here also the ECG electrodes. The upper ones were about like here. And as a second step, this you don't have to necessarily perform, will be the calcium score. So in very young patients that don't have a high coronary artery disease risk, you would not have the calcium score. In all others, we routinely do this in our protocol. And this is normally from the carina of the trachea up to the dome of the diaphragm and the lower range of the heart. And according to the Eggertson's convention, Eggertson was a researcher that did a lot of standardization and research initially on calcium scoring. The calcium score is performed with 120 kV, which is, of course, more dose than low kV scanning, but because the Eggertson scoring is so nicely standardized among all different races and age groups, it's still performed with 120 kV. With most recent scanner softwares on the 3rd generation dual source CT systems, you can also perform it, and this is standardized by several studies with 100 kV. This is facilitated by a tin filter, and this may reduce the dose for the calcium score. And when we have then this unenhanced image, this will be the image impression from the image on the axials you will get. You can then define the level of the test bolus. So the test bolus will be at the ascending aorta at the level of the main pulmonary artery approximately. And you put a region of interest inside the ascending aorta. And when you don't have the calcium score image acquisition, you can also assess based on the topogram. Like it would be at this height approximately. It should definitely be in the ascending aorta. Don't put it too low when you don't have a calcium score, but because then you will have the aortic valve and the aorta moves like circular like here. So you should have it perpendicularly cut for the test bolus. Also, what I do in younger patients, for the test bolus, you can also reduce the kV. So if you have a very low, very lean patient, you can also do this test bolus images with 70 kV. Then you get a bit more noisy image impression, but you are still able to detect the iodine signal in the ascending aorta. So you will get the images in exactly this plane after you inject the test bolus, and then you measure the attenuation curve. So you measure the time point when you have maximum opacification in the ascending aorta, and you use this time delay to perform then the subsequent coronary CTA. The coronary CTA is then a bit more narrow as compared to the calcium score, because of course now you exactly know where the coronary start and where they end. It's just important at the lower range, it is from a diagnostic view less important to visualize everything, because this will be just the very distal coronary artery parts. On the other hand, the dose relevance here is more, because you have the liver, you have the spleen, so you will, everything that you reduce on the inferior part will lead to significant more dose reduction as compared to the upper range. On the diagnostic side, on the other hand, the upper part of the image are much more important because they visualize the proximal and the stem of the left coronary and right coronary artery. So don't narrow this window too much here, because the patient also, when the patient will feel this warm sensation during contrast media injection, they will probably breathe a bit differently than in the other topogram and calcium score, just because they are maybe a bit confused of this sensation. And we had cases when we were too aggressive with dose reduction that we cut off a tiny branch of the LED, for instance, and you don't want to run into that. So this slide shows actually the main cardiac CT scanning protocols. They consist of a prospective and diastolic image acquisition, that it's used at equally or below 75 beats per minute heart rate, and a prospective and systolic protocol that is used above 75 beats per minute heart rate. So despite that we give beta blockers and instruct the patient, you may have still slight higher heart rates, and then it would be not possible to scan diastole because you would have too much cardiac motion. However, it's actually desired to assess the cardiac dimension that the heart is in diastole. That's why we always try to better scan an end diastole, also because the dose will be a bit lesser. In the first case with end diastole, we have a scan window of 65% up to 75%. And in the case of end systolic scanning, we would have a scan window of 200 up to 400 milliseconds. And this would almost be equal to 30 up to 40% of the RR interval. If you really want to go to lower dose levels, you can also narrow the scan window further to 68 up to 72, for instance. However, when we scan 10% of the heart cycle, this, in the case of motion artifacts, allows us retrospectively to also play around with the best phase, and then you probably can overcome some motion artifacts. The rest of this protocols is completely the same, so the delay for the actual image acquisition is first the delay from the test bolus plus the time to peak. That means you have to add those two values. And then you have preset values like reference kV is 100 kilovolts actually, and reference MAS, that means milliampere per second. It defines the tube current, is with the flash scanner second generation 380, and with the force scanner third generation dual source CT it's a bit less, 300. So you have a bit lesser dose with this third generation scanner hardware. And the slice collimation also differs in terms of a greater Z-axis coverage with the force scanner. It's 192 slices actually, and the scan direction will be craniocaudally, and for dose reduction or dose modulation you have the CARE KV, which again is the topogram based KV selection, and you will also have the CARE dose for the enabled, which is an automated tube current modulation. This technique works in real time, so during the scanning the detector is counting the photons, and if two less photons reach the detector, you will have a more tube current. And CARE KV, on the other hand, is only decided once in advance, so you can't dynamically modulate this in real time. For even lower heart rates, we have another potential with dual source CT scanners. That means turbo flash or high pitch acquisition. The pitch is a factor that defines the table motion in relation to what is actually scanned during one gantry rotation. So with single source CT, it's limited to 2. With dual source CT, we can have a higher pitch like 3.4 with flash or 3.2 with the summatum force. And that means in lesser time you can acquire the same volume. That means also less dose and less motion artifacts. However, in case of a high calcium burden or also stents, you may change the care KV settings to semi. That means it will be not always it would not always choose the lower KV, or also you can switch it off and give a bit more KV in case that you really want to be on the safe side and don't want to run into blooming artifacts. For very challenging cases like tachycardia or arrhythmia, severe arrhythmia, we have also the potential to not ECG trigger but scan the entire heart cycle and retrospectively then detect the cardiac phase with the least motion, however at the cost of very increased radiation dose. So we only use this very in shock patients. You can imagine above 100 beats per minute, that is like not very frequently found, but in those cases we want to be on the safe side. Another potential is if you want to do functional cardiac analysis, which will also be covered in a later tutorial. So with this, because you scan the entire heart cycle, you can also, like in cardiac MRI, you can define the ejection fraction and all the volumes from the right ventricle and left ventricle, for instance. Also regional wall motion abnormalities you can assess, or valve analysis. However, also this has quite higher radiation dose in comparison to our turbo flash high pitch or the prospective scanning protocols. And together with my two mentors in my home institution, we developed here the scanning algorithm, so it very defines very nicely which protocol is actually to be chosen. We check the ECG initially and first look for arrhythmia. If we have no arrhythmia, then it's on depending on the heart rate, we choose with 65 below, we choose the high pitch protocol, and then depending if it's above or below 75, we choose end diastolic and systolic, or the retrospective spiral acquisition in very high heart rates. And if we have arrhythmia, if we say yes, then we ask ourselves, how severe is the arrhythmia? If you have only one extra systole or one R wave, one abnormal R wave, and then you have in relation to that 3 normal R waves, so you have to count them about a range of 30 seconds, then you choose the prospective end systolic protocol, which is also very dose effective. And as you see, this is the same as here. So basically this part is the same in this algorithm, makes it much easier. And if we have severe arrhythmia, that means we have more than one abnormal R wave every 3 normal heartbeats, then we also choose the retrospective spiral acquisition. And then very important is also when you have the images acquired, how you reconstruct the images. In case that you have a calcium score acquisition, that will be the case in the majority of patients. At the console, you will reconstruct 3 millimeter calcium score kernel images. And from the same acquisition, you also reconstruct lung and bone images. And this is because you have first a wider scan window. And on the other hand, you have 120 kV dose. That means you have very sharp image impression for the lung tissue as well. You would lose some parts of the lung if you would do the lung and bone out of the CCTA data. Also, at the console, you reconstruct, or actually it is automatically reconstructed, everything. You reconstruct 0.6 millimeter soft tissue kernel aligned images. Aligned means that usually when you